So, as was mentioned, I'm going to talk about the future development of heart disease in women who have certain complications in pregnancy. But first, I'd like to acknowledge that the land from which I'm presenting today is the traditional, ancestral, and unceded territory of the diverse Indigenous peoples, including the territories of the Musqueam, Squamish, and Tsleil-Waututh First Nations. And I speak with much gratitude and humility and pay respect to the First Nation, Métis, and Inuit peoples all across Canada. I also want to provide this disclaimer, and that is that the information that's provided in this session should not be considered as medical advice and is not intended as a substitute for medical professional help or guidance or diagnosis or treatment. Always please seek the advice of your physician or other qualified healthcare provider with any questions you have regarding your medical care. The learning objectives are that by the end of this presentation, I hope that you will be able to understand how common heart disease is and that you will be able to share how symptoms of heart disease can be different in women, share it with your families, your friends, and also be able to explain the risks for heart disease. And we'll talk about the traditional risk factors like high blood pressure and diabetes and smoking. But then we'll also talk about what many people, including our physicians, our nurses, our midwives, many healthcare professionals are not up to date on some of this information that I'm going to provide you with this shortly. So these would be the sex and gender related, as well as what we call the under-recognized risk factors for heart disease, especially in women, but also some in men as well. And lastly, I hope that you will be able to understand the pregnancy-related conditions and their future cardiovascular risk, not just in women, but also in their offspring. So, heart disease, since 1990, so over the last, 30 years, has been the number one cause of death globally. And you can see that here in 1990 and then 2021. And even today, heart disease is the number one cause of death. And then the most recent data have shown that neoplasms or cancers have dropped from second to third, and respiratory infections such as TB have become the number two cause of death. Now, this is globally. Now, Monica already showed you this slide, and when somebody shows you this slide twice in a presentation, that means it's really important. So, cardiovascular related death in women is rising in Canada. And this slide, let me guide you through it. So these are death rates. These are not rates of having heart attack or stroke. These are actual death rates. And so the Canada is the dotted line, which is Canadian males, and then the straight line in red is Canadian females. And then these are all high income countries, so Australia, United Kingdom, but we'll just also look at maybe the USA, which are in this teal greenish kind of color. But you can see that for Canadian women, there's a rise, an ongoing, continuing rise in the number of deaths from heart disease in women. In men, the red dotted line, it seems to have tapered off, but you can see that in women in the US, in Canada and Australia, the UK, these solid lines, they're continuing to go up. So again, heart disease not only is the leading cause of death for women worldwide, it's actually the leading cause of early death. So in women between the ages of 35 to 55 in Canada. And also you can see now, hopefully, that it is continuing to rise in these countries. Now, what do we mean by heart disease? Heart disease, you may have heard being described also as cardiovascular disease, and it's really a general term for a variety of conditions that affect all the blood vessels in our body. So, not just our heart, but our brains, our arms, our legs, in the abdomen as well. And this, you mostly have heard about heart attack and stroke. So, these are all heart disease, heart rhythm issues, valve disease. And what happens is this process of atherosclerosis, where you get this plaque buildup in the arteries. And this can start again in our early 30s, where you get proteins and fats and other inflammation in these arteries, and they build up. And sometimes this little plaque can rupture, developing a clot which blocks your artery. Or this plaque can continue without rupturing, but it ends up being so big that it blocks the whole artery. And that cuts off the circulation, leading to the heart attack or the stroke. And the burden of heart disease in women is quite high. It's really not only a man's disease. And here are some statistics for you from the Heart and Stroke Foundation and other publications. One Canadian woman dies from a heart attack in Canada, now we're talking, every 20 minutes. So in the next hour when we finish this session, 3 women would have died from a heart attack or a stroke in Canada. And in 2022, heart disease killed 7 times as many women as breast cancer. And women living with diabetes are 3 times more likely to die from heart disease when compared to men. Women are not referred to rehabilitation programs as often as they should, less than 50%. And women are 60% less likely also to regain independence, going back to their usually activities of daily living after stroke. And unfortunately, more women, twice as many women, go to long-term care facilities after their stroke when compared to men. So I just want to share what a risk factor is. So risk factors are characteristics or behaviors or traits that increase the chance of developing that disease. It doesn't mean that you necessarily get that disease or that health condition, but it increases your chance or your risk of developing that condition. Now, risk factors for atherosclerosis or heart disease or stroke can be categorized as modifiable, which are orange in color, or non-modifiable or genetic. So you can see that high cholesterol, high blood pressure, diabetes, being overweight, or being a person with obesity, having an unhealthy diet, smoking, or being inactive, these are all considered as modifiable risk factors. And then there are conditions such as a family history of early heart disease, one's age, one's sex, and other factors, proteins that cause clots. These are all factors that really we cannot change. So we really need to focus on these modifiable risk factors, which are actually 80% of the risk factors. So the good news is that we can affect our future development of heart disease by targeting these risk factors. So we've talked about these traditional risk factors already. What is not also known is that these risk factors, they are actually a more dangerous risk factor in women. They have higher death rates and higher illness and hospital admissions in women compared to men. So it's, again, men also get these risk factors, but it's actually a more worse outcome in women. Let's focus now on these female-specific as well as the under-recognized risk factors that I've listed here, but we'll talk about in a bit more detail. So Monica showed a different version of this slide, but heart disease in women begins really, really early, in fact, at the time of conception. And this relates to abnormalities with regards to the placenta, which we'll talk about more in the next slide. And then if one has irregular or early periods or a family history of heart disease with pregnancy complications, polycystic ovaries, or what we call these maternal placental syndromes, like, preeclampsia or eclampsia, gestational diabetes, gestational high blood pressure, or even preterm birth or miscarriage. These are all coined maternal placental syndromes. And these are risk factors for heart disease. Even rheumatoid arthritis is one of the polling questions, or lupus. These are considered risk factors, and these autoimmune disorders occur more in women. Having your menopause early, under the age of 40 or 45, and even radiotherapy or even some certain chemotherapy drugs for breast cancer treatments are all risk factors for the future development of heart disease. And then, of course, we know the menopause. So the other thing to mention to you is that pregnancy is actually considered to be a woman's first stress test, right? So this stress test is not just for 9 minutes, which is the average duration on a treadmill, but it's actually for 9 months. So pregnancy is a very, very good predictor of the future development of heart disease. So we call these adverse events in pregnancy APOs, okay, adverse pregnancy outcomes. And these include, and you can see on the table on the right, all the different forms of high blood pressure. So pre-existing high blood pressure, so high blood pressure before pregnancy, developing high blood pressure during pregnancy, a more serious form of high blood pressure called preeclampsia, where other organs are involved, like the liver as well as the kidneys. And then preterm birth, I mentioned, so delivery before 37 weeks, really early preterm birth, miscarriage, I mentioned, or small babies, and then gestational diabetes. These are all adverse pregnancy outcomes. And these occur in about 20% of all pregnancies in Canada. And they are, as I've said a few times already, they are associated with an increased risk, which is an up to an eightfold increased lifetime risk of having a heart attack or a stroke or other vascular or blood vessel diseases, as well as developing diabetes or high blood pressure in the future. And these future events can occur about 10 to 15 years earlier than they would if a person did not have these complications, these APOs during pregnancy. And there's also data to support the fact that there's increased risk of depression in somebody who has an adverse pregnancy outcome. Now, these APOs not only affect the mother, they also affect the children. So, offspring of women with APOs are known to develop high blood pressure, or at least increased risk of developing high blood pressure, increased weight, diabetes, and heart disease, even as early as in their adolescence. Let me move on to this very, very helpful tool. It's called the FIGO Pregnancy Passport. You can just Google FIGO, FIGO Pregnancy Passport, and you'll get to the link of this very, very handy support. And this is something, women should print out and share with their, um, you know, healthcare professionals, whether it's their family doctors or whether it's their midwives or their nurses. And it asks for, your blood pressure, your weight, all kinds of questions about yourself. But then it also asks about your baby's information from any previous pregnancies. And then it goes through some risks that you can take off. And then it also gives you suggestions on how to manage your blood pressure in terms of diet and nutrition. Of course, you would need to have an obstetrician or a cardiac person or a cardio obstetrician involved in your care as well as, of course, your regular obs-gynae person if you have any of these adverse pregnancy outcomes. Cora, there's somebody who's waiting in the waiting room, if you wouldn't mind admitting them. All
Okay.
right, so make sure you download this form and share it with your caregivers. So now I want to jump to the under-recognized risk factors, and these really are relating to mental health and what we call the social determinants of health. So anxiety, stress, chronic stress, depression, these are all risk factors for the future development of heart disease. And, it's this psychosocial roles as well and behaviors that are imposed by society. And so, I call it being the type E personality or the type E woman. And that's when, you're almost forced to a certain extent because of society's expectations to be everything to everybody every time, right? So you're the cook, you're the caregiver, you are the driver, you have all these responsibilities, plus you could be working, you're cleaning the house, all of these things that many women are felt to be important in terms of their responsibilities in life. And then there are other disadvantages, such as being unemployed or being alone or lonely, not having enough social support, friends, or, communities, poverty, disability, not having, even a high school or university education, and even your postal code, where you live. If you live in a rural area, is a risk factor because you don't have access to healthcare. And then, domestic abuse and intimate partner violence are risk factors. And then, I always say, let's not be colorblind. Our race and our ethnicity and being of indigenous heritage also increase our risk of cardiovascular disease. Moving on to the last sort of third of my presentation, I want to talk about heart attack symptoms. So, um, in both men and women present most often. So this on the left here, this rectangle on the left, men and women present most often with chest pain, but they may describe it as a tightness or a pressure, or a discomfort or even a heaviness. So when somebody describes, a tightness, they also mean chest discomfort. But in women, they have quite often associated symptoms. So women may have nausea or heartburn or upper abdominal discomfort or even upper back or shoulder pain. They may have even profound fatigue and or weakness or feel short of breath or feel dizzy or lightheaded. Or they may even feel their heart racing. And sometimes they can have, in addition to this chest pain, they can have even three or more of these symptoms. Now, men can also have nausea or these other symptoms, but women present more often with these symptoms in addition to the chest discomfort. And I just want to share this slide, which shows that, for the policymakers that may be joining this webinar, in the 2021 census, the total racialized population in Canada reached, over 10 million people, which was, 26.5% of the overall Canadian population. And the largest racialized group was of South Asian origin, followed by Chinese and Black populations, and then other diverse groups as are shown in this diagram. And there was a 50-50 split actually in terms of men and women in these groups. So it's important for, when we want to develop inclusive approaches in healthcare policy and research, it's really important to understand this information that I've just shared on this slide. And again, the burden is very, very high in South Asians, both in men and women. We have the highest rates of heart disease, high blood pressure, and stroke compared to other ethnic groups. And deaths due to heart attack and stroke occur 5 to 10 years earlier than the Caucasian population. And in South Asian women, diabetes and high cholesterol develop at a much lower body weight compared to other ethnicities. So you don't have to be a person with obesity or a high body mass index to develop these conditions. South Asians have unfortunately higher hospitalization and mortality or death rates, and there's at least a twofold higher risk of diabetes amongst South Asians. And just to discuss this in a little bit more detail, I just want to share some information about, the future. These conditions are not going to go away. You can see on these maps here of the world, the top one is 2015, and red color shows that there are very high prevalence of high blood pressure in these countries that are red. And down here is the predicted. It's a model that the literature in this article uses to predict about, 15 years from now in 2040. When you can see that in certain countries in Africa, like in East Africa, Kenya, Tanzania, South Africa, were yellow in 2015 are now red. So there's going to be more high blood pressure predicted. And then also yellow in 2015 in India and Bangladesh, but it's going to be red. The prediction is that high blood pressure is going to increase in the next decade in these countries. The same with diabetes. This is from the International Diabetes Federation. This data is from 2024, and they're predicting what are the rates of diabetes going to be in 2050? So around the world, diabetes is going to be increasing anywhere from 142% by 2050 in Africa, and in Central Asia by 92%, and 73%, in India and the Indian subcontinent. And right now, 1 in 5, this was one of the polling questions, 1 in 5 live births are affected by gestational diabetes, and this is also likely to increase. So it's really critical that we take these conditions, especially diabetes and high blood pressure, very seriously in our communities because it's really not going to get better unless we do something about it. And this leads me to prevention. So it's not all doom and gloom. As I suggested before, 80% of these risk factors are manageable, are preventable, and mostly with, first of all, lifestyle measures. So being active, losing weight particularly, keep moving, reduce your portion sizes. So use a 9-inch plate as opposed to a 12-inch plate, and eat more fruits and vegetables, less carbs, and much less red meat. Manage stress with, Tai Chi or meditation, things like that, as well as stop tobacco smoking and vaping as well, stop alcohol intake, and get regular checkups. And even realize because of the genetic predisposition of the South Asian community to these conditions, even though you may pick up these conditions early, medications may still be required above and beyond lifestyle measures, depending on how much risk is involved, other risk factors, and as well as the severity of the condition. I'm almost done. I think I'm probably out of time, but these are some tips that I like to share with people because they may not realize that they are in charge. So when you are meeting with your healthcare provider, please prepare for your visit. Make a list of the health concerns you want to talk about because otherwise you might forget something. But do keep in mind that you may only have time to talk about one thing, so prioritize your concerns and then go back and see, your doctor or your health care provider about other concerns that you may have. And bring a list of your medications so that the doctor or the nurse can help you right there and then and not have to call you later, or you don't have to call them back later to see if your medications need adjusting. Write things down, discuss things, but also make note about what decisions you arrived at when you have spoken with your healthcare team, so that you'll also remember and can refer back in your future conversations, and that you'll remember what you need to do. Bring someone with you, a trusted friend or a family member who can also help you take notes or ask questions. And then if you don't understand, don't hesitate to ask. Ask about what did the healthcare professional mean. Ask for definitions. We use terminology, very, very readily because it's what we do, but we may not realize as healthcare professionals that the person sitting in front of us, our patients, may not be may not have heard the terminology before. So don't hesitate to ask questions so that we can explain in plain language. So my take-home messages to you are life. We don't want to miss it. So I hope you realize now that cardiovascular disease is a now problem. It's the #1 killer of men and women, and it affects women particularly at younger ages. Adverse events in pregnancy, those APOs we talked about, are risk factors for heart disease for both the mother and the child. And South Asians are at much greater risk of heart disease compared to other groups. Know your risk factors. We've talked about the traditional risk factors, but remember there are sex and gender risk factors as well as other risk factors that are under-recognized. And we can do a lot, a significant amount of improvement and prevention can happen with lifestyle measures. And get screened regularly and start the conversation, with your children, your siblings, your parents. Really, knowledge is power, and prevention is the key. So thank you very much.